thank you all for being here. I really appreciate having such a big audience. This is wonderful. And we have people from as far afield as, I think we've got somebody from the Netherlands, we have people from Spain, Portugal, and of course we have all the speakers from America. So thank you so much. I can't tell you how grateful we are, especially for speakers who come over from so far from America. Dave Clark, Howard Schubiner, David Hanscom, we've got Peter Zafarides who will be coming later, and Fran Summer Anderson later on today because she's running a workshop at the moment as well. So welcome everybody, and thank you for being here.
I was at the Tate Modern yesterday with my wife, and I came across this painting. It's called House of Pain by Rebecca Horn, 2005. So are you guys awake? Yes. You all had coffee, you're awake. Now let's see if you're alive. What do you feel? Can you provide a sound effect for this painting? Hey, you're alive. Audience responsive. I don't know if you can see, but the head is over here. Disembodied, disattached from the body with all this crazy stuff going on, shooting inward and shooting outward, all this red, fiery stuff, body in pain. And I learned, after 25 years of being a physician, I learned that I didn't know two major things. I didn't learn the power of the mind, and I didn't learn the nature of pain. And I've spoken to lots of groups, and I've spoken to lots of pain groups, pain doctors, pain physicians, and I'm convinced that we don't really understand this. And so I'm going to try to talk about this a little bit. First thing is, how powerful is the mind? Everyone knows the mind can cause paralysis. It's called a conversion disorder. But we think of that as a rare disorder, like it only happened every now and then. I saw a teenager with this, and his arm would be paralyzed. He'd wake up in the morning, his arm would be fine. He'd go to school, his arm would be dead. Put it in a sling. He was being teased unmercifully all day in school. At the end of the school day, his arm would be fine again. Unbelievable. And if you read Ed Shorter's The History of Psychosomatic Medicine, you'll see that paralysis was much more common in the older days and now much less common. Well, we have deep tendon reflexes. We can tell with an MRI and a deep tendon reflex quickly distinguish conversion disorder from Guillain-Barré, from stroke, from lead poisoning or whatever. And it doesn't happen so much anymore. Cardiogenic shock, broken heart syndrome, surprise, happy birthday, go into congestive heart failure. It's a powerful effect of the mind on the body. Nick Stratton is here. He's an expert on voodoo. Voodoo can kill you. It's that powerful. And I spoke to a group of pain physicians at a prestigious hospital in the United States, and I said, pain can be contagious. And they looked at me like I was wacko. Totally wacko. But medical students get pain all the time when they study in the unit that they're studying on, or nursing students. And husbands can get pregnancy symptoms when their wife is pregnant. And you can read an article about RSI, or you can read an article about something and get that symptom if you're sensitive, if you're sensitized, which is what we're going to talk about. And hallucinations. Oliver Sacks just wrote a great book called Hallucinations. How many of you have ever had the sensation of your cell phone vibrating in your pocket when it wasn't? It's the most common hallucination now. And it is normal, as Dr. Zafarides would say, you're sane. And so stress-related symptoms, if the brain can cause all that, how could it not cause pain? How could that not be the case? I mean, that's absurd to imagine that it could cause all these other things and not cause pain. And obviously the brain and the mind have powerful effects on the body. The body has powerful effects on the mind. Do you want to increase your mood right now? Do you want to increase your mood right now? Elevate, or as they say, lift here. Lift your mood. Take your pencil right now for 1 second, or your pen, put it in your mouth, like this, put it in your mouth, and just see how that feels. Because guess what? I just made you smile. Oh, thank you. It's good to smile. All right, are you ready to provide some sound effects? See if you're alive, okay? Could you provide sound effects for this slide? Very good. So this is a slide. This is a slide of a picture very similar to a friend of mine who's a Canadian construction worker. He shot a nail through his finger, and he drove to the hospital, and he had how much pain? 0 pain. He had no pain at all. Pain is a function of the brain. He had no pain. For some reason, the signal in the brain, the pain signal, the danger signal, the alarm signal, the whatever heck you want to call it signal, did not activate. But it happens all the time. Kids skin their knee and may not cry until they see their mother come running. And so he had no pain. Can you provide sound effects for this slide? You see the nail through the boot? So this is a 1995, it's written in the British Medical Journal. British construction worker jumped off a scaffolding, impaled himself on the nail, had a lot of pain. When he got to the hospital, they gave him IV narcotics, IV sedation, because it was hurting so much. And they removed his boot, and as it says in the article, a miraculous cure was observed because the nail was between his toes. He was not injured. And my patients are always shocked at this. They go, oh my God. So if you understand the first slide with the nail in the hand, that didn't cause pain. And you understand this slide with the nail in the boot, that did cause pain, but there was no injury. And you understand this slide, which is a picture representing a patient I know, or a friend of mine, a doctor friend of mine, who came up to me after a lecture, and he said, when I was a young man in Vietnam in 1969, that was me on the stretcher. I took shrapnel wounds to my left leg. Our company was ambushed. There was a lot of blood. There was a lot of gore. And I got medevaced out. I came home stateside, rehabbed. Pain went away. Limping went away. I was fine. 20 years later, I'm walking down the street, and all of a sudden, I get the same pain and the same limping in the same leg. And what had happened? I said to my wife, what's going on? And my wife says, do you hear that? And there's this helicopter buzzing by. So pain can be learned, can be memorized, can be reproduced by the brain in response to a trigger, which is somehow connecting into that danger signal, into that alarm signal in the brain. So these 3 things explain pain to me more than I ever understood pain before. Are you with me? Yes. You're still alive. Good. So all pain is real. It's not real pain or imaginary pain. It's not legitimate pain or illegitimate pain. And all pain is caused by the brain. Pain is a function of the brain. It can be triggered or generated by tissue damage, and also can be triggered or generated by neural pathways. And the difference between these two, they're not the same. You can have both. Most people who have physically tissue damage pain will also have what we might call psychogenic pain on top of it. We are wired to have pain. Our brains are connected to every cell and fiber of the body. The amount of pain that can be caused by the brain can be mild and can be overwhelming. The severity of the pain is not a clue to the cause of it. Patients have a hard time wrapping their head around the idea that this much pain could be caused by their brain. But there are clues to determining it, and a very careful and detailed history and physical and review of lab tests and imaging can help to decrease this diagnostic ambiguity between tissue damage pain and psychologically, or brain-induced pain, or neural pathway-induced pain. That's the term that David and I seem to like most now. And there's lots of stuff in the middle. But if we never make the attempt to resolve that diagnostic ambiguity, we're often mislabeling and diagnosing and mistreating people, which I would argue is a big deal. And so our brain has evolved to have this danger signal. And it's necessary. You need to know when you touch a hot stove, your brain gives you a message that is so strong to learn not to touch a hot stove again. It's very finely tuned. And as Peter and I were talking last night, it's designed to be overly sensitive, because if the rustle, as Peter was saying last night, the rustle in the bushes is not a tiger and you jump away, fine, you're still alive. But if it is a tiger and you don't jump away, you're dead. And that's how we are wired. We are wired to remember these kinds of things. And so an injury causes the signal to the subconscious mind to either activate or not activate the danger signal. And if the danger signal is activated, then we get pain, the conscious experience of pain. And an emotional injury, an emotional threat can directly activate the danger signal to create pain. And once that occurs, I seem to be going in the wrong direction. Oh, that's why, because I'm hitting the wrong button. And once the pain occurs, the pain pathway is established. There's a neural pathway that will be remembered, just like the guy with the helicopter. And so our brains have evolved, and it's the basis of what PTSD is. And it turns out, this is PTSD. We all have a form of PTSD in that sense, because we have remembered difficult things. And David and I think Peter and I were talking last night about, I love my father to death. He's dead. I loved him I still love him. But he, the things that he did that were negative, God, those are like seared in my memory, all those little things. And our brains are just set up that way. And when you talk to people and you take a careful history for the stress and hurts which activate the danger signal in their lives, so a typical story for a patient of mine might be something like a woman who as a child had a controlling and hyperly critical father, let's say. And there's no symptoms, but there's the danger signal being activated in her brain. And when she's 15, she has a boyfriend who's all nice and kind, but then he starts sending lewd pictures of her around the school and calling her names and sleeping with her best friend. And now she starts to get migraine headaches. And when she's 25, she marries a guy who seems to be nice but turns out to be a jerk and starts being emotionally abusive or even physically abusive, and maybe to her children. And now the danger signal is getting bigger and bigger in her brain, the sensitization. And now she starts to get pelvic pain and irritable bowel syndrome. The onset is at that age. And then she's 35 and she divorces a jerk, but he's not paying child support, and he's trying to turn the kids against her, and the danger signal is getting bigger. And then she starts getting pain all over. And then she gets diagnosed with something else, which you already know what she would be diagnosed with. But there's different names across the pond here, right? The ME and the fibro. Anyway, and then she gets in a little fender bender and her neck starts to hurt. And then the neck pain travels all the way down her spine and she has anxiety and depression. And so the symptoms are building. And then she goes to a doctor who says, well, let's look at your neck and back. We'll get an MRI and we'll attack that directly. But they're not looking at the whole person. They're not looking at the progression of things and what's going on in the brain. They're just looking down here in one little corner, because now she has 8 different doctors, and each one is looking at one different part of her body. So can the brain create pain? Well, in Derbyshire and Pittsburgh, they gave physically induced pain and hypnotically induced pain, and the brain looks the same. Physically induced pain and brain-induced pain are exactly the same. And the pain of fibromyalgia, or ME, as you may call it here, is real. It's not imaginary. All pain is real. And this is from University of Michigan. And when you take people with back pain, they also have this thing we call central sensitization, or central pain amplification is a medical term for brain-induced pain. And when you can measure that by giving a dolorimeter to your thumb and measuring what's happening in the brain as you increase pressure to the thumb and at what level of pressure patients report pain. And emotional pain causes physical pain. Physical pain causes emotional pain. This is from University of Michigan also, a friend of mine, Ethan Cross. And what he did a very cruel experiment. He gave people physical pain and scanned their brain, and then he gave people emotional pain and he scanned their brain. And the emotional pain, this is the cruel part, the emotional pain he gave people was showing them a picture of their lover, ex-lover, who had dumped them in the last 6 months. This is a cruel experiment. To show them that picture. And when he showed them that picture, the pathways that were activated in the brain were exactly the same as the pathways activated by a physical injury. Emotional pain can cause physical pain. And at UCLA in California, Naomi Eisenberger and her colleagues gave people an experiment where they made them feel socially isolated and socially excluded and scanned their brain. And they found that the anterior cingulate cortex activity increased, the same activity as producing chronic pain. It's more complicated than that. And that when people had social exclusion, their pain sensitivity increased, their pain threshold decreased. Emotions connected to physical pain. And we know that PTSD is connected to fibromyalgia and irritable bowel syndrome. These are highly overlapping conditions. In fact, I would argue they're part and parcel of the same condition. And we know that fibromyalgia is associated with childhood victimization, the early sensitization of the brain in some way, shape, or form. And we know from the ACE data, the Adverse Childhood Events data, it's getting a lot of publicity now in the States. I don't know if you're hearing about it over here so much, huge amount of publicity showing that childhood adverse conditions are associated with almost any adverse outcome that you can, health outcome that you can imagine in adults. And childhood and adult victimization is also seen in higher rates with migraine headaches, interstitial cystitis or painful bladder syndrome, pelvic pain syndromes, irritable bowel syndromes. And this amazing study from the early 90s in Los Angeles, a spine surgeon was looking at his results and he said, I wonder if childhood adverse events have anything to do with it. So he took the people and they were having spine surgery. They all needed spine surgery from his point of view. David Hanscom is going to talk about this a lot in a minute. And he took them and he divided them into 3 groups. Those with no childhood adverse events, 95% success rate in this study. Those with 1 or 2 childhood, these were things like abandonment, divorce, parental drug use, parental abuse or sexual abuse or physical abuse. But those with 3 or more, their success rate was only 15%. It's amazing because we're talking about people that he thought had a back problem. And the 95% rate is caused by what? Just teasing. I'm being provocative here. The placebo effect. Just being provocative. My spine surgeon colleagues don't like when I say that. It may not be totally true. I mean, it depends on the person. You have to have diagnostic certainty. The best as we can possibly do. Some people need spine surgery. I get it. Anyway, so, and from Chicago, Abkarian took people coming in the ER with subacute back pain syndromes, and he scanned their brain, and then he saw what happened, how many people developed chronic back pain, how many people didn't. And the ones who were more likely to develop chronic back pain were those that had a high rate of functional connectivity between the nucleus accumbens and the prefrontal cortex. This is a highly emotionally laden area. People were sensitized at the beginning of their injury, were the ones, their brain was sensitized for whatever reason. And we look at, if you look at pain studies, they say, well, let's look at catastrophizing, people who catastrophize, people who worry excessively, people who, when they get an ache, they go, oh my God, I'm dying. You know, I've got a headache, it's a brain tumor, Woody Allen syndrome. And so they, but this was there, and they say, well, it's catastrophizing. So I asked this guy from Harvard, no, from Brown, you know, so what do you think causes it? Have you ever looked at childhood adverse events? No, we haven't looked at that. What do you think causes pain catastrophizing? There's a reason people are more likely to be catastrophizers, because their brains have been sensitized. Now, not to say that genetics doesn't play a role, but I'll talk about that in a minute, if I have time. And John Burns in Chicago showed that people who had back pain, when he asked them to recall a time when they were angry, their paraspinal muscles tensed up. Their paraspinal muscles got really tight. Their trapezius muscle didn't get tight, their blood pressure didn't change, their heart rate didn't change. It wasn't an overall fight or flight response. It was a very specific reaction between an emotion of anger and tightening of back muscles. Really interesting. And so Eunice has looked at this, and this is a famous slide that most pain doctors have seen. And it's the idea that there's something overlapping. There's this overarching thing of pain sensitization or amplification or neural pathway pain or psychophysiologic disorder. To me, they're all one and the same. Some people would argue with that, but when you take myofascial pain syndrome and TMJ syndromes and migraine and tension headache and irritable bowel and chronic fatigue and fibromyalgia and PTSD, which is kind of part of this, as I was describing, an irritable bladder syndrome. And I never talk about dysmenorrhea because I don't like to, women and their hormones, I stay away from I stay away from that. But it's the idea that these things are all connected in some way. And when you look at the genetics, you say, well, let's talk about depression. So we know, well, genetics, depression is genetic, anxiety is genetic, migraine headaches are genetic, as if that one word describes the whole thing, right? It's genetic. But period, end of story. Well, there's no doubt we're not born with clean slates. We have genetic predispositions. There is no question about that. And this is a study with the short and short long and long alleles of serotonin-related gene in the brain, or gene everywhere. And but who's more likely to develop depression? It's those with higher numbers of stressful life events. It's not people with zero low numbers of stressful life events have the same level of depression, no matter what genetic loading they have. But over time, the ones with the short had higher levels of depression with higher levels of stressful life events. But then, if you look more carefully, if we talk about the field of epigenetics, how stress influences gene expression. And so, here's a study from Sue Taylor in Los Angeles, and they looked at short, long, and long. Well, the short is supposed to be the bad one, to have higher rates of depression. But then she broke it down by early family environment, which was risky, not nurturing, and nurturing, happy, friendly, good early environment. And it turns out that it's probably that this gene sensitizes people. The ones with the risky life events had higher rates of depression, but the ones with the nurturing had actually lower rates of depression than people who supposedly had protective genetic profiling, if you see what I mean. It's how our life and how our environment influences our lives, influences our brain, influences our genetic coding. And this is an amazing animal study from Montreal. I don't know if you've seen this. This study blows my mind. They took mice. This is cruel. I apologize. But they took mice and they cut their nerves in one of their paws. And they had a control group that they didn't cut anything. But the injured group, they cut their forepaws, and they measured how they responded to mechanical stimulation, how much it hurt, basically, measuring pain, to cold stimulation, and then they looked at their brains. They looked at methylation. They looked at epigenetic changes in their brains in terms of their gene function, and then they divided the injured group into two groups. The environment where the mice were in a cage alone with food and water and no toys to play with. And then they gave the other group the enriched environment, where the mice were with other mice that they could play with. They had wheels to run around, and they had the same amount of food and water as the non-enriched group. Are you with me? So they call that the impoverished group. They weren't impoverished. They had plenty of food and water. They just didn't have friends, and they weren't enriched socially, and they couldn't play. Anyway, so, but what they found is that there was a big difference between the group that got the enriched environment on their pain compared to the group that had the less socially engaged environment. And in terms of their pain in relation to cold, and in relation to the methylation in their brain. The ones who had the enriched environment changed their brain in terms of epigenetic coding, epigenetic expression of genes, which had an effect on pain. And David might talk about this. What if we put people in enriched environments? How might that have an effect on pain, especially pain which is caused by the brain in the first place? It's a powerful combination. And so what I tell my patients is pain is a message. When I was having diarrhea, it was a message, right? I was an intern, but my brain was giving me a message. But the question is, how do we interpret the message? How do we understand the message? What is it saying? That's our job to figure out what the message is. We can look at objective finding. We can rule out a structure, a clear structural disorder. I live in fear every day of telling someone they have a neural pathway disorder when in fact they do not. And in fact they have, and every time I hear a story like Nick was saying, they say, well, we had a patient who had a spinal abscess. It's just, there's fear through my body to do that. But the alternative is to be diagnostically ambiguous and say, well, everything's the same, it's just pain. It doesn't matter. We'll just treat it as pain, as opposed to drilling down and saying, what's the cause? What is really going on here? Because the treatments are different from my point of view. And so, you know, when someone gets an injury, what happens is it heals. You get a scar and you feel, and the pain goes down. That's the natural course of an injury. It hurts and then it gradually gets better over days, weeks, or months, or whatever. But not years and years. When you get an injury and the pain goes up and then it stays up, or it gets worse over time, why is that? Unless you can from my point of view, unless you can document some level of physical disease that's happening there, when their tests are normal, that's not that hard to figure out. That becomes it started out as a tissue damage problem, and it has now become a neural pathway problem. The exam is very important. What kind of findings do we have? And then if you look at, so you're doing your exam, you're doing your imaging, you're doing all that, but then look at the life of the person and see, where does it fit into play? Was the childhood difficult? Were there priming events in childhood that I talked about? Are there other symptoms? Is this someone who has a congruence of a whole list of symptoms that occurred at different points in their life? Are the triggers anticipation variable? Does the pain occur in one chair but not sitting in another chair? Does the pain go away when you're on vacation? Does the pain shift? Does it get worse when you're on your way to visit your mother-in-law? No offense to mother-in-laws. I saw a doctor the other day who was convinced his pain, because he's a cardiologist, he's convinced his pain because he was wearing this heavy fluoroscopy jacket for all these years. And he's done research on this. He's proven that 60% of cardiologists get back pain because they're wearing these jackets. And I said, well, 85% of normal people have back pain, so it's not that bad. You know? And I examined him. His back is fine. There's nothing wrong with it. I said, you can do this and this and this, and it doesn't hurt. And I said, stop it. You're fine. Stop it. You're fine. It hurts when I stand. And I said, well, stop it. You're fine. Tell yourself you're fine. He said, oh my God, you're right. He hasn't had a pain since. I mean, it's for some people, it's making a clear and unambiguous diagnosed. He was getting injections, he was getting Alexander, Feldenkrais, Rolfing, he was getting all this stuff. But he just needed someone who understood that there's a neural pathway pain and there's a non-neural path, structural pain. And so if you give people a little questionnaire and say, which of these potentially neural pathway disorders have you ever had in your life? And I have a friend who's a interstitial cystitis doctor, and I said, well, how many of your patients have migraine? He said, I don't know. Well, how many of your patients have irritable bowel? I don't know. How many have back pain and neck pain and fibro and headaches? I don't know, because I'm only looking at the irritable bladder problem. But if you look at this, these events started in childhood. These events started in 1981. I think something might have happened in 1981, don't you? What happened in her teen years? And then what were some of the relationships between divorce or marital problems or other life events and when symptoms began? And what was your father like? First word she says is cruel. That's not a good sign. How was your mother? First word is passive. I mean, this speaks volumes. And it's just, what we have is a great treatment, but it's for a very few patients because nobody wants this. That's a problem. That's our job, to change the perception and the culture of understanding that, my patient can say, oh my God, I'm so happy it's not in my head, it's in my brain. Great, that's perfect. And what our patients need to get is, it's not your fault. The symptoms are real, but they will not harm you. You are not damaged. This is a huge thing. Your brain has been sensitized. It's creating symptoms. These are due to neural pathways. Most people have this. You can get better. We have data from our hospital where I work. Mean average duration of pain, almost 9 years. 57% with significant childhood trauma. Number of symptoms, 13. The average number of symptoms is 13. These are lifetime symptoms. Most people presented with fibromyalgia pain or neck and back pain, or both. More than 50% improvement after 1 month of simple treatment, simple understanding and simple treatment, 43%. And at 6 months with no extra treatment, 53%. 53% with 50% or more reduction in pain is pretty dramatic. Reduction in pain for a very simple treatment with people with chronic and severe pain. It's a little randomized controlled trial we did where we randomized people with fibromyalgia to a mind-body approach versus a weightless control. Pain went down and stayed down. We have an NIH-funded study now. We're doing a 3-arm study comparing CBT to an emotional-based intervention. Results will be out in a year or so. And so basically, first step is education. Understanding this is a neural pathway problem. Believing it is, having confidence in yourself. That physician that I talked to you about, that's all he needed, was to understand it. I saw a lawyer who had back pain, and he said, I get, I know it's my stress, I understand this, we went through his whole life, but every time I go like this, it hurts. There must be something structural. Because every time I go like this, it hurts. So I said, okay, well, go like that. How much did it hurt? He said, it hurt this much. And I said, good. Now, stop and think for a second. Just say to yourself, I'm healthy, I'm strong, there's nothing wrong, I'm fine, I can do this, I'm in charge, I'm in control. Oh, do this. Oh my God, it was like that. And then I said, good, do it again. He goes, oh my God, it's like that. So immediate feedback between changing your brain and changing your body. And he got better in 1 month, and that's all he needed, was stopping fear, taking control, challenging those triggers and doing more rather than doing less, because doctors tell people you have to baby your back the rest of your life. That's the worst advice you can get. We're going to talk a lot about this afternoon. I deal with emotional work in particular. ISTDP, we'll talk about that. And then finding life changes, finding meaning and peace and joy, being assertive, being loving, being forgiving. And so I already talked about the educational intervention. I have to be very quick. But it has to do with having a chance for post-traumatic growth. And if you don't believe this, go to the TMS Wiki. Go to thankyouDrSarno.com if you want to hear about people who've recovered. It's unbelievable. Georgie talked about documentaries in the work. Moving forward in your life with genuine indifference to the pain, focusing on living as opposed to focusing on pain, stopping having the pain have control over you. But you can do that if you understand and you believe that you're okay. It's much easier to have less fear about pain when you realize it's a paper tiger, when you realize you can get better as opposed to, well, I've got a back pain, but I'm going to cope with it. And the difference between most pain-centered, most CBT-centered treatments is that the assumption is you've got pain, we don't know what's causing it, we'll help you cope with it. Versus this is a bit different because it's saying we know why you have pain and you can get better. And so this was a lady who said, I had a huge success today, I was in a bit of pain, but I was determined to walk in my neighborhood. I said to my brain, I'm walking today. You can make it easy or you can make it difficult. But I'm doing it. I walked about half an hour, my pain lessened. This was a huge breakthrough for me. I was astonished. And ISTDP is emotionally based treatment. It has very powerful results. CBT treatments, effect sizes are in the range of 0.2 to 0.4. ISTDP treatment effect sizes are a bit higher in many studies. And so this is a diagram I don't have time to show you. But it has to do with doing emotional work, going to the hurtful place, getting in touch with anger if there's anger, accessing guilt if there's guilt, expressing sadness and grief, and moving to love. And so I'm going to give you an example of this from a patient, not a patient of mine, a lady who started reading this work and started doing it on her own. And she said, lucky. That's how at 18 years old I described being raped at knife point. Lucky. A lot of women get raped and murdered, I told myself. I'm still alive. I have no right to feel sorry for myself, to be angry. 30 years later, debilitating migraine led me to read Unlearn Your Pain. That's my book. I got angry at my rapist for the very first time. I screamed, you have no right to touch me, over and over until decades of pain erupted like an exploding volcano. I imagined my neighbor and I kicking his crumbling ass to the ground in the courtyard. I finished the story with the police arresting him. I began to heal a wound I never even knew that I had. I don't remember ever thinking I deserved to feel compassion for myself, no matter how bad the situation. There was always somebody who had it worse. This caused me to take care of everyone else and put my needs last. This personality trait brewed from an upbringing that I think must be common. My mother loved me, I never doubted that, but I could not also emotionally reveal myself to her without having her judge me. So when she got raped, she didn't tell her mother because she didn't want to disappoint her mother. So instead of letting things out, I began an extensive catalog of fear and shame and trauma deep inside and just kept smiling. This is so common amongst people I see. And so everyone said, she's so strong. No one ever saw me upset or angry or rude. I did everything I could to ignore my body and my brain's attempts to get my attention. It wasn't just migraine, it was back spasm. It was abdominal pain. It was knee pain. I just never connected the dots, never understood the message that my brain and my body were trying to give me until 3 months of she was hospitalized for migraine at this point. So severe pain. I found the person in my life who was doing me the most harm, the person who held the key, the only one who could unlock the anguish was me. The realization of how much pain I had caused myself now layered on me in a heavy blanket of sadness and grief. To heal, I needed to allow myself to feel the grief as it welled up and to feel the anger. Not only did I have anger toward the rapist and towards my own mother, but to someone else. I found that I would literally have to divide myself in half, and on one part I would express anger toward a part of me. For 40 years of utter neglect of my emotional needs, and it came up quickly and boiled over and gave me an instant feeling of healing. My migraines went away. But healing the other part of me is more difficult and ultimately more important. It's the painstaking process of rebuilding a broken relationship with myself. It's reconnecting with someone I abandoned long ago, myself. And it's the learning, maybe for the first time, to be a loving and compassionate caretaker of myself. This is a simple concept. Stress and unresolved emotion create real physical pain via neural pathways. These are caused by the subconscious brain. They can persist for years because the more they become learned, the more they become reinforced every day, every minute of every day by monitoring them, paying attention to them, keeping a symptom diary of them makes pain worse. And there's 3 studies that show that. Reversal can occur by cognitive, behavioral, and effective interventions. And how common is this? Joel Conoco works with David in Seattle, said, I know, he's a pain doctor. I've been working in pain for a long time. I knew the trauma had some role in pain, but since I've understood how the mind commonly generates pain and how to recognize that process, which I've tried to point out is quite relatively easy, I recommend that I realize the majority of my patients have this syndrome. This is the last slide. Any sound effects for this? Jody's brain. Abuse, 6-year-old little girl part. Stand up for the little girl or neglect her. Stand up. And that's the message of this work. Stand up for ourselves. And we have to stand up to people who tell us that we're damaged when we're not. And David will talk about that. So thank you very much.